I love this question because it's 3 words. Dopamine or epinephrine? That is the entire question.
It's easy.
Happy.
So, I guess my guttural response is, I don't care as long as you get them out of shock. I mean, I don't know. I think we could argue proarrhythmia back and forth both ways till I don't know that it really matters whatever you have your hands on, and I don't know where this came from.
That's true.
Neither nor epinephrine.
Well, not currently an option
For us.
for out of hospital.
But for out of hospital, we don't have dopamine in our boxes. You
We
have
only
one
have
of
epinephrine.
those.
Yeah.
No, it's still on our, and so again, my interpretation of this, lacking any context here, is this is somebody that
has it in their protocol.
Well, maybe not. Maybe my age, like I grew up on dopamine.
Sure.
I had to know this to pass. We just talked about this on our education podcast. I had to know this to pass registry. It's just beat into my head. I mean, still to this day, I can, mix it and do all these things. And then, if I had both of these agents, which would I choose?
I believe in 2015, AHA came out, and that was one of the pushes as well. It was in 2015 or 2020 when they listed some of their options. They, I believe, from their documentation, preferred epinephrine or norepinephrine over dopamine.
Well, the answer for almost all shocks, norepi,
Correct.
max your norepi, and then you can go down to your seconds. My second after norepi is going to be an epi drip.
Is epi, right?
Yeah.
My preference has changed from dopamine to epinephrine.
But that's what you were trained on,
that's
right?
What
you were
we
so
all
used
started
to
with dopamine.
practicing, and now that more data comes out, practice changes.
And some of that is the operational side of my brain is, why do I need another thing in my box if I've already got 5 gallons of this in there, right?
Yes.
How I deliver it, whether in a dilute form or in a concentrated form or, I mix it in a drip, how I deliver it, that also opens up for providers that don't keep up on that, the opportunity for an error, right? Because now we have the same thing, but we're going to give it 27 different ways. And Epi's probably the poster child for that, sadly,
Because of the routes. The routes.
Because we use it for so many
We
things,
do.
right?
Different concentrations, sure.
Right.
Honestly, epinephrine and ketamine are probably our jack of all trade drugs in the box. There's multiple indications, there's multiple doses, there's multiple routes for those medications, and we use them as the jack of all trades. Right?
So we're answering another question.
Hey,
What is the most common medication errors in EMS, and how do I avoid them? I think it'd probably be those.
Well,
two.
there's 6
ketamine.
rights.
Those 2 drugs come to mind, right? I feel like we do have occasional other.
Ondansetron, olanzapine, but
Yeah, we
Those-
have some lookalike
those are
sound-alike,
lookalike,
but
that's it, that's it,
lookalike
sound
sound-alikes,
alike
but I
errors.
think we've also, specifically to us, so other people that are listening to this might not have that, but if you're not in our state or under our protocol, work with your pharmacy. I think pharmacists, any suggestion we've made to pharmacy for like, hey, this is a lookalike sound-alike, we need some sort of a safety barrier, and Zyprexa and Zofran, I'll just use the easier words to pronounce first.
bad Ray, use generic.
All right, ondansetron and
olanzapine.
olanzapine. Sorry, I was trying to I always mispronounce both of those. That's why I give Zyprexa and Zofran. But pharmacy plays a very active role in what we do here in our hospital system, where you're thankful for them, and that's why we put Zyprexa in a bag with a bright green label that says this is Zyprexa. So a lot of those lookalike sound-alikes, the design of your drug box can go into trying to avoid errors, right? You either put drugs together that go together. Normally for let's go back to your anaphylactic, I have epi and Benadryl together for lack of a better word, and then polar complete opposites. I have racemic epi and low pressor or labetalol. Yeah, one of our 2 beta blockers in the drug box. So it's in design, lookalike sound-alikes. But I do agree, epi, because we can use it a multitude of different ways, different routes, and then same thing with ketamine. So you just have to be smart and realize what you are utilizing that drug for, and make sure you have the correct concentration.
I feel like
Sorry, now
in our med control, our medication errors, our dose errors. Let me clarify this. Our dose errors fall on epi and ketamine, and our wrong agent fall outside of that. And it usually comes down to a look-alike, sound-alike.
Yep.
I grabbed the green-capped drug because that's what my IV Zofran has been, and it was oxytocin.
Yes.
Right? I mean,
No, yeah, no.
right, though.
Seriously,
that was
yeah.
literally that failure. Is they
Correct.
grabbed the 2 ml green-capped because the Hospira, green-capped Zofran looks exactly the same, right? But I feel like our dose errors fall in those categories with epi and ketamine.
And to that point, I mean, we've recently launched an app and to do things to make those dose errors even less. We use products like Certidose to make offloading in pediatric cardiac arrests, offload that cognition to tools.
We don't even need this. Because you're answering another question. How do I calculate medication doses safely for pediatric patients? And frankly, all patients.
Yeah.
Cheat.
Yeah.
Cheat. Cheat.
There's no cheating after registry.
Cheat. Right?
No,
Use a
because
tool.
You're
Use a
using
tool.
a tool in a highly stressful situation to give you the desired outcome, which eliminates the risk of wrongly
Reduces.
reduces.
Let's
All
read
right. Sorry.
I would
reduces,
love
reduces the risk. No different. Like, I mean, one dose is awesome. The app
Have a
is
giant
phenomenal.
robot that slaps your hand every time you
Bam,
pull
bam.
it.
Oh, sorry.
That's wrong!
Pulls the tape off your arm.
And then, Certidose, let's take we're very good at med math, right? So if I have that pediatric cardiac arrest where I'm like, I need to give 0.01 milligrams per kilogram of epinephrine to this pediatric patient, I can get how many milligrams I need to give to that child.
Not the hard
it's
part
the
of math.
volume.
Always
the
the hard part.
volume is the problem now. So use Certidose,
Health
use
Mobile
one dose.
is starting to get better about that. Hantevi is out there, and we're starting to utilize Hantevi, and it's nice. Certidose has been great, but again, it's low volume. We don't see a lot of peds calls, so it's usually the adult calls that we're more worried about. But then again, one dose has made that pretty easy.
Yeah. Well, I still think you should do, like, one of the things I will say, our guys pride themselves on it, and we probably do this, I don't know, at least a couple times a year. How often do you open your ped bag, right?
Yeah.
How often do you open the ped bag that's color-coded and pull out the PD tape, whether it's Braslo, whatever name brand you want to use. Braslo is just an easy one to say. Whatever color-coded, weight-based,
Well,
tape. Do you know how to utilize it?
Can you use it head to foot or foot to head, or is
Right.
it unidirectional?
Correct.
Can you use it both?
Is it height or is it age?
There's
is
a
it
reason.
weight?
As dumb as that sounds.
But you got to know your
It
equipment.
says measure from the head.
Yep.
Like you have to look at whatever brand.
If you're using a
Product.
tape, yep.
It says measure from this way. You have to pay attention. You flip it around, you could be very much so in the wrong. So yes, you need to know how to utilize your equipment. Hands-on skills and reviews, and since it is a high risk, low volume, low frequency, high risk, you need to pull those types of bags out, go through them. That's a good training.
But that's not even just medication. If you overbag a pediatric patient, I mean, you're going to bleb them. You have to know your clientele.
Very recently, we've had a large number of pediatric arrests at my shop, and so we just did a review this morning of one of them, and I even brought up one dose. Like, maybe we do move this into the hospital setting.
Oh yeah.
Like, is this going to make things easier for everybody just to have an app to help? I think on this patient they used the color tape and they used Certidose after talking to the doc, but after doing a further review, like, is there an opportunity here to use another safety net to say, what is our dosing for electricity on a pediatric patient?
Yeah. Certidose has an app as well that'll coincide with that. One dose, Certidose. I mean, there's a lot of tools. Yeah,
There are a lot of techniques and tools.
Yeah, I mean, there's tools out
There's
there
multiple.
to even do like timing of your medications and doing your 2 minutes of CPR and doing your rhythm reassessments, and even if you turn on your metronome and for CPR
Code Runner.
and
Code Runner's a good one for that. Yeah, I love that app.
use all those tools. Offload as much as you possibly can.
Cheat.
A lot of them are free or very cheap.
Or if you're part of a large organization like us, maybe your organization provides those tools to the providers to be safer and provide better care.
What is the correct pre-hospital management for a seizure patient who is postictal?
Supportive care.
Yeah, supportive.
Check a glucose.
I think
Prepare for another seizure.
Yeah.
Yeah, recovery position.
Yeah, make sure you get a
they're
pat
protected.
line if you can. Airway's good.
Yep.
Cap no.
If they vomit, yeah,
100%.
cap no.
Yeah.
You might need to pad your cot.
Yeah, prepare for the next. If you haven't been into the drug box already, this might be a time to pull the med out.
Have it ready.
Maybe not necessarily draw it up,
Have it
but
ready.
you know, I tongue in cheek say, you know, have it taped to their forehead, but you know, have it immediately available if.
Yeah, crack the main seal. Put the controlled substance box next to you with, you know, the
Correct.
with the agent, syringes and everything that you might need. Yeah.
Have your draw needle on your syringe ready to
Ready
go.
to go.
I mean, how many times we talk about for doing airways, but having your crike kit or whatever whatever you're going to fail to, just sitting there and ready so you know where it's at.
Yep.
So that way you
Also,
don't have to go
though,
looking for it.
providing they're not trismus, look in the airway, make sure they didn't bite their tongue down, and you don't have a blood problem.
Oral adjuncts are great for those patients too.
Yeah, nasopharyngeal airway. I've gotten some mileage out of those.
All those things, but I think the asterisk should go next to check glucose.
Yeah.
I said the sugar.
I know.
Got the sugar.
Because you got to think. I mean, when that patient has a seizure,
They're using a lot of
they're
energy.
using a
and
lot of
glucose
energy.
storage.
They're burning a lot of oxygen. They're burning a lot of glucose for sure.
It either caused it or
Yeah.
As a side
they
effect.
consumed
Sure.
a lot, right?
Yes. Yes.
I would even go one step further and say serial glucose checks if you have a longer transport.
That's a good point.
Because you know
You can see a
what.
dip.
Well, I mean, likewise, you have a big sympathetic release. You're going to see a spike, and then if that settles back down, if they turn around, burn that right back off in the next 10 minutes, if you got a 30-minute transport time or something.
I mean, 1 point a day is not good enough.
Still is the case. Multiple points to draw a line.
What?
Yeah,
So-
crazy.
I'll play devil's advocate. Why don't I need to do that in an awake patient then?
Their mentation tells you a lot.
Yeah, you're talking to them. Your ongoing assessment. They're communicating with you. If they just go out. And,
I don't know. My guttural response to that is why wouldn't I do it in an awake patient? I've had patients walkie-talkie AO4 with blood sugars of 32. Yeah.
But you're also not
Everybody's
generally
normal is
just going
different.
to treat it
Yeah.
because they might live there. So
Not at 30.
Not at 30.
They're getting
No,
treated
you're still gonna
in
give
my
them something.
in my truck. They're getting treated. You know, even if
I'm
they're
guessing I'm thinking like low 60s. Like let's say
different story.
you're teetering, but at the same time, if you're talking to me,
Yeah.
you're going to tell me better than I would tell you that you need treated.
There's, you know, I'm certainly not pulling, you know, IV medications out for that patient, but
30s, yeah, that's a bit low. Or
Yeah,
calibrate your glucometer for the love of God.
it's reasonable to, you know, the equivalent of doping your tube is to, you know, rule out equipment failure if it doesn't match your patient presentation. I mean, who at this table hasn't taken multiple finger sticks on the same patient
And
because
it's 15, 20 off every time from each
No,
other.
no, no. I was just saying, you know, from the perspective of you had that same presentation I just explained, right? Is, you know, they have a blood sugar of 32, but I feel fine, and you're like, that doesn't match the clinical. This doesn't match. This doesn't add up.
And not to get on a tangent about glucometers,
But you're going to anyway.
get it from the right source, though. It's got to be, you know,
From the
capillary blood.
end of the nose.
Yeah, well, that'll work, but don't do
You can't
venous
use venous blood?
No.
I'm joking. I'm joking.
This will be a little bit of a zinger too. But when is it appropriate to downgrade a call from ALS to BLS?
I feel triggered now.
Yeah.
Can I start with don't be lazy, or is that inappropriate?
No.
It's
Okay.
not. It's not. And I really think this has to be a very cognizant decision of resources available. You know, you really have to be resource limited in my mind to...
Like everything, it always depends, right?
Correct.
If you're downgrading because you're lacking resources and you believe that this patient could go by a double basic unit.
And safe, right. I mean,
Yeah.
what I didn't finish saying there was I'm resource limited and it's a safe and appropriate.
A rolled ankle can go by a double basic unit.
Yeah.
If I need a paramedic or an advanced or an intermediate or some higher level to then take care of the other patients on scene, Absolutely.
Yeah.
Now, going back to carbaceous material in and around the mouth should not go by a
Potential
basic,
for,
yeah,
right.
potential for,
Yeah.
even if you're resource limited, maybe you've got to make a judgment of who gets the more advanced care, but that patient's going to be very high on my list to be able to get paramedic care all the way to the hospital.
In your case, you're presenting there's multiple patients once seen.
Also, yeah.
Let's just.
Let's say it's a paramedic engine intercept that gets to the patient first with a paramedic engine
And
unit.
BLS crew.
And then a BLS crew responds with an ambulance. Like, do you hand that patient down? I think is more what that would be asking.
That could be a scenario, or
I guess depending on what interventions were already provided, the triage status of that patient, and then the comfortability of your basic crew, and maybe distance to the hospital.
Well, I think it could come from another place because I got this a lot when I was the coordinator at John's shop.
We had a lot of
we had a lot of mix. So it was the question was asked. Okay, go there. I assess the patient. I do a 12 lead. I do all these things. I'm like, you're a BLS skill. I'm like, why wouldn't you just finish it? Like, why would you? Obviously, you thought enough to complete steps A to Z.
Yeah.
Why would you not want to continue that during training?
Without deficits in any of those steps
Yes.
either.
Yeah,
So
they're
the
like, well, I didn't
patient's
find
still
anything.
stable. And
Yeah, but their point was, well, I didn't find anything wrong, so I've done an assessment, so can I turn it over to an EMT? And I didn't really like that. We've talked about that a couple times.
I would say chest pain never, or chest pain
Oh, yeah.
equivalent.
Sure.
Never.
AMS in any sort.
Yeah.
I don't know. I just felt like if you had the mindset to do all of those things, and then just because you didn't find something yet, I don't believe it's a great reason to just say, well, I'm going to downgrade
there's
it.
a reason
Does
they
that make
called
sense?
to begin with. Yeah.
There's a reason yes. Maybe you just haven't found that answer yet.
Yeah.
So keep hunting.
Abnormal vital signs.
Absolutely not.
Hyperglycemia. We have this codified in our protocol a little
Correct.
bit. But just generally thinking that if you think that they're going to possibly need an advanced interaction, that's an ALS call.
Yeah.
Make it an ALS call. Just go with them. That's why they called you.
Correct.
They called for that level of care.
Right.
Now we know that in my area and lots of places we only have
Sure.
basics, and basics do a lot of good things, but there are times where you need that higher level of care from an advanced, intermediate, or paramedic. So if that's what you think is going on, that's what the patient should get. What would you do if it's your own
family?
mom,
Yeah.
Right.
whoever you like? I mean,
Yep.
it kind of all comes back to that. I know for the episode you guys just recorded, Fallon talked about the scoring of
Yeah.
her as a paramedic. So like you pass whether or not I would want you to take care of my loved one.
Yeah. When is glucagon indicated for beta blocker overdose? So, again, I think this is coming from a person who was trained long ago, and without trampling over what we just did from the educational podcast, kind of the textbook registry answer still includes glucagon. It does factually work in beta blocker overdose. It's the dose that is usually problematic
That you can't
Yes.
get in the pre-hospital
that we
setting.
just don't have enough.
No.
And I have absolutely seen this in chart reviews, never personally, but patients get IV glucagon for beta blocker overdose, have a quick trend up in heart rate,
Well, now it's a basic call, right?
and then it's
That was good. I like that.
and then minutes later, because it was only 1 milligram, settles right back down, and you're in the same spot. And that's the reason why we don't, on our side of the world in pre-hospital in this region, we've kind of kicked it to the curb and said, if you're hypotensive and bradycardic from beta blocker overdose, give more beta. And we have lots of beta in the drug box in the form of epinephrine, right?
Yeah.
So this is push-dose epi, this is epi drip, or dopamine if we go back to the previous question.
Or pacing if we absolutely have to.
A sympathomimetic to
there was
directly oppose that
there was
suppressed sympathetic state.
And I agree with you that this question was probably asked from someone that's been in the field a while.
yeah.
And obviously, we know clinical findings change as research continues to evolve, even in the pre-hospital setting. That's why we drifted away from glucagon. Availability went on shortage for a very long
It did,
time.
yep.
I remember when we used to have 3 glucagons in each drug box, and that was probably over $200 and some per dose. Yep. So you're north of 600 or 700, and most of it was expiring.
Yep.
So, and then we went on shortage, and then we obviously looked at the data that said, no, we already have a drug that's, what's a vial of Epi, $6.
Yeah.
That's already there. We can essentially use one of the tools in our toolbox that's already there for something else.
This conversation almost exclusively gets I'm adding this because it's not in here, but in my experience teaching protocol review classes and whatnot, this almost exclusively gets followed up with, well, we can still give it for esophageal foreign bodies, right? That, again, coming out of that entire time frame, we were taught a whole battery of things to use glucagon for. It was like a drug that was just searching for indications, right? And so same thing, esophageal foreign bodies. What's the current practice on that side? And I mean, I can quickly state that there was a large multi-center randomized trial that prompted us to take it out of the drug box because both arms, the placebo arm and the esophageal foreign body that got IV glucagon, the ones that went for mechanical retrieval were essentially the same in both arms. Was the decision point why it came out of protocol. This is now 10 years ago, right?
Functionally, that's a little different, and it's GI provider preference.
Yeah.
GI providers typically would prefer not to come in at 8 o'clock at night to take out that chicken bone or chicken wing or whatever.
Pork chop.
Or
personal
pork
experience.
Chop. Yep. Or it's Mr. Pork
I
Chop.
will tell you that glucagon hurts like crazy.
Doesn't feel great.
And 2 of them hurts even more. And then when that doesn't work, lidocaine mixture doesn't work, you go for a bronch retrieval.
But provider preference from
a GI standpoint, we'll call the on-call GI provider, and some of them were like, "No, don't do it. I'll just come in." Some are like,
"I'll grab it."
What of all the things did you try in your toolbox to not have me come into the hospital at night?
And how many times is that Hail Mary?
Honestly, I use a combination of effervescent granules we use in radiology to effervesce and move things around that we get a good
positive result
amount of movement from, and
nice.
Honestly, it saves surgery for the patient, so that's the benefit.
That's always good, right?
Yeah. So I mean, I typically will throw glucagon at them, and I will throw the effervescent granules at them to see if I can get it to move, and that's why I see the patient, I do those things, then I call GI, and
I did things, where are we at?
Yeah, and I will sometimes get yelled at, depending on the provider, why'd you do that? I'm going to come in anyways, or, did it work? Have you tried soda, and have they tried jumping up and down?
I tried that.
So
yeah, and that was kind of the thing. Everybody's like, well, I've seen it work. I've seen it work too.
I've never seen it work.
But that could have been a function of, to your point you just made, that could have been a function of me hitting a bump on the ride to the hospital.
Absolutely.
Or that could have been a function of the drug.
Yep.
We simply don't know. But we've kind of just left that up. Position of comfort, treat pain, and then let you guys sort it out on the hospital side of things. You guys have anything else? We got a couple more in here, but they're gonna trigger everybody at this table more than.
I think that was cool, and I think that if people have more questions, definitely submit them.
Yeah, fire them off. All right, well, guys, it's been nice to all of us back here at the table again, and we will catch you all on the next one. Thank you.
Thanks.